Hello everyone. In this part, let's study something about IgA nephropathy, IgAN for short. IgA nephropathy, the most frequent form of idiopathic glomerulonephritis, represents 15 to 40% of primary glomerulonephritis worldwide. The hallmark of IgA nephropathy is the predominant deposition of galactose-deficient IgA1 containing immune complexes in the glomerular mesangium. IgA nephropathy is an important cause of end-stage renal disease, and it is not a benign condition. The initial manifestations of IgA nephropathy are variable, ranging from acute, rapid, progressive, and chronic glomerulonephritis. Most IgA nephropathy patients have elevated circulating levels of IgA molecules that are galactose deficient at the hinge region. The predominant form of IgA is composed of polymeric IgA1. Patients have circulating IgG and IgA autoantibodies against this galactose-deficient IgA, and then the resulting immune complexes deposit in the glomeruli, leading to an inflammatory reaction and consequent glomerular sclerosis and interstitial fibrosis. IgA nephropathy often presents either as a symptomatic microscopic hematuria with or without proteinuria, the most common presentation in adults, or as episodic gross hematuria after an upper respiratory tract infection or exercise, the most common presentation in children and young adults. Approximately 20 to 50% of all patients have hypertension. Increased serum IgA levels noted in 1/3 to half of cases do not correlate with the course of the disease. Serum complement levels are normal. Some patients presented as renal dysfunction. The diagnosis of IgA nephropathy is established by finding glomerular IgA deposits as either the dominant or the co-dominant immunoglobulin on immunofluorescence microscopy. Deposits of C3 and IgG also are often found. Light microscopy varies from the most common pattern of mild mesangial proliferation to severe crescentic glomerulonephritis. By electron microscopy, immune type dense deposits are typically found in the mesangial and the paramesangial areas. The pathogenesis of IgA nephropathy may involve abnormal antigenic stimulation of mucosal IgA production and subsequent immune complex deposition in the glomeruli. Efforts to treat the disease by preventing antigenic stimulation, including broad-spectrum antibiotics, tonsillectomy, and dairy manipulations, for example, gluten elimination, generally have been controversial or unsuccessful. Trials using fish oils to decrease proteinuria and slow progressive disease have given conflicting results. Controlled trials support the use of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers to decrease proteinuria and protect renal function. Randomized trials suggest that a 6-month course of reduces both proteinuria and the risk of the kidney failure. ACE inhibitors or ARB with glucocorticoid therapy appear to be of incremental benefit. There are conflicting data on the benefit of immunosuppressive agents. For example, cyclophosphamide and the cyanoprin mycophenolate mofetil for the few patients with chrysanthic IgA nephropathy. Cytotoxic agents have been used. The course is variable, with some patients showing no decline in GFR over decades and others developing nephrotic syndrome, hypertension, and renal failure. Factors predictive of a poor outcome include hypertension, persistent proteinuria greater than 1 gram per day, male gender, and elevated serum creatinine level, and the histologic features of mesangial and endothelial proliferation and sclerosis or of tubular interstitial damage and chrysanthic formation. Levels of galactose-deficient IgA and levels of autoantibodies against this galactose-deficient IgA correlate with renal prognosis. Renal survival rates are estimated at 80% to 85% at 10 years and 65% at 20 years. A significant percentage of transplant recipients have a morphologic recurrence in the allograft, but graft loss is uncommon. Okay, that's all. Thanks.